All right, we are recording and let me just share the screen.
Hi, everyone. Good afternoon. These are all new faces to me. Hello.
Can you use that one?
Whatever one. This is good. Vegeta, yeah. Okay, I can hear myself. Hi, good afternoon, guys. My name's Simone Renaud. I'm a fourth-year medical student here at David Geffen, just matched. I have the distinct pleasure of introducing to you today Dr. Tatiana Salisbury. Dr. Salisbury is senior lecturer in global mental health at King's College London and the London School of Hygiene and Tropical Medicine, which I had the great privilege of being in their joint program for the Masters in Global Mental Health last year. She is also the co-director of the WHO Collaborating Center for Research and Training in Mental Health at the Institute of Psychiatry, Psychology, and Neuroscience, which is the leading neuroscience research institution in the world. And she is assisting the WHO in developing evidence-based methodologies for studying the burden of mental and neurological disorders worldwide, as well as policies and programs aimed at alleviating that burden. It is good to have her back in our state, your home state, yes? As she got her degree in human biology at Stanford University before moving away to England, where she got her master's in evidence-based social work and eventually her PhD in psychiatry. So just a little personal touch. While all of our lectures in the master's program due to the pandemic were like me and my PJs under covers on Zoom, I distinctly remember Dr. Salisbury's lectures in participatory research methods and human-centered research design, particularly as it relates to adolescent maternal mental health in Mozambique, which I'm sure she'll talk about at least a little bit today. Among all of these lectures on developing the evidence base for mental health service provision with RCTs, it's the language that we as future physicians really view our world and our delivery of care. What stuck out to me was Dr. Salisbury's work in helping health service providers actively engage with young people in the development of these scalable and sustainable solutions to transforming their own mental well-being and their own wholeness and connectedness. And I thought that that is the evidence base that we desperately need and should be caring about in this day and age, and of which I hope to one day be a part. So I am honored to have Dr. Salisbury joining us this afternoon. And I'm equally chuffed to be joining all of you in hearing her speak about how we rethink providing mental health service delivery. Dr. Salisbury.
Oh, perfect. Thank you, Simone, for such a lovely introduction. And thank you so much for the invitation to come and speak today. And it's great to see you. This is kind of one of the first times that I've been in person and with people, and I can see your faces and I can see if you're interested or if you're nodding off. So it's just really nice. Even if you are nodding off, I'm just happy to have you here. So thanks so much. So today I'm going to talk to you about the work that I'm doing that is part of a fellowship that I'm currently undertaking. It's funded by the UK government and it's called a Future Leaders Fellowship. So it sounds really kind of intense and no pressure, I guess, for me to become a leader. Actually, to apply for it, you have to already be a leader, so it's a bit of a misnomer. But the idea of it is that it's something that is a bit innovative and a bit high risk in terms of what it is that we're doing. And I think in Europe and in the UK, this kind of work is a bit innovative and a bit different. But I think as my tour across kind of the Western states of the US has shown me is that there are a lot of colleagues here that are doing very similar types of work. So I've been learning and I've been really happy to be in the company of people who are using very similar techniques and methods and talk about the challenges to those things, as well as what the opportunities are and kind of the successes that we each have had in the types of methods that we're using. So today I'm talking about opportunities for actually changing the way that we develop and interact with mental health care and support. And the great thing, one of the things, a positive thing to come out of COVID, I think, is the public's understanding of the relationship between environment and social changes and mental health. So these social determinants on mental health. So we're at a really great, I think, point for the field of mental health and the field of global mental health to take advantage of that understanding, that openness, that interest in mental health, to say, you know, we've been working behind the scenes to figure out what are the things that we can do and what would be useful. And now please kind of let us do these things. But in the same way, I think it's important for us to remember that each context is different. And so we can't just go around doing what we've done previously of taking kind of existing evidence and saying, oh yeah, well, we need that, so we're going to take that and we're going to use it here. So we have to, if we're going to do that, we have to know how to adapt that to the context and make sure that the intervention actually fits with kind of the customs and the beliefs and the behaviors of the people in which that intervention will be placed. Which one is it? That one. There we go. Okay, so I know that not everyone has a very strong kind of mental health background, and I think it's important for us to be all on the same level as we move forward. So I'm just going to go through a few mental health kind of background notes. So if we think about mental health, what is it that we know? So before, you know, lots of people might think, oh, this affects other people. There aren't that many people that are impacted by mental health. But from research, we know that over a lifetime, 1 in 3 people, every 3 people will actually be impacted by a mental health condition. And so you can extrapolate that further and say that that's a lot of people also that know from experience people who have gone through difficulties with their mental health. We also know that childhood and adolescence is a particularly important time for mental health. This is a time period that really kind of lays the foundation for our resilience, or potentially increases vulnerability to mental health problems. So there was a big study that was conducted several years ago in which researchers asked people who have mental health problems, when did your symptoms begin? So not necessarily the mental health problem that they had at that point in time, but when were other kind of either other mental health conditions or just kind of simmering mental health issues that didn't necessarily meet a threshold for a disorder, but the symptoms were there. And 50% of those people said that actually those symptoms began before their 14th birthday. And 75% said actually it happened before their 24th birthday. So that's, you know, 3 in 4 people who are adults experience a mental health problem actually had those issues, you know, way earlier in their lives. And so this for me was kind of a no-brainer that actually, if we want to do things to prevent mental health conditions and we want to promote good mental health, then actually moving backwards in time of where we're focusing our efforts is really, really important. And that's kind of what brought me to the interest in adolescents and young adults. Then we can think about, well, what are the risk factors? So in this, really what we're thinking about are the kind of negative impacts of mental health. And these are, these are the risk factors. So what are the things that increase someone's potential for having a mental health problem? And so those include poverty, gender discrimination, poor nutrition, poor educational attainment, physical health conditions, natural disasters, and violence and conflict. And that's not everything, but that's, you know, a big chunk of it. And so these are a lot of the social determinants of mental health. So these are external things that actually impact people's mental health and their ability to kind of cope with the challenges of day-to-day life. And we know that poor mental health affects, amongst other things, social relationships. So in cultures where there's especially high stigma towards mental health issues, that people with mental health issues often have a difficult time engaging and forming relationships with others or keeping relationships. And that sometimes then also extends, that stigma extends to their wider family or other social contacts. So there's a big impact on social relationships and the social networks for support. And we also know that social networks and support have an impact on mental health. So it's this kind of circular problem that we have. Also issues around educational attainment and then economic prospects. So it's, you know, these are things, mental health is something that kind of permeates everything that we do. It permeates physical health issues, it permeates kind of social issues, economic issues. And so it's a really important thing for us to tackle. And if we can improve mental health, then we can also expect to see really good gains on all those other indicators that we want to see globally that shows that the world is becoming kind of more prosperous, more resilient, and thriving. So despite the prevalence of mental health problems, despite all the things we know about the negative impacts, governments on average spend very little on mental health. And a lot of this is related to the stigma. On average, governments spend 2% of their health budget on mental health. So that's already kind of 2% of another budget. And that has knock-on effects, and especially around mental health resources. And for human rights resources, we know that globally, there's one mental health professional for every 10,000 people on our planet. And if you look at that in terms of countries, that's where there's a huge shift and a huge dichotomy in terms of resource. So high-income countries have more mental health professionals. I'm not saying that they have enough necessarily for the demand, and you might kind of realize that for the waiting list for mental health care. But in low and middle income countries, it's particularly acute. So when I started working in Mozambique about 5 years ago, I had a meeting with 2 psychiatrists. And I remembered I told them, kind of as a joke, I'm going to make this quick because I know your time is really valuable and there aren't very many psychiatrists in the country. And they said, yeah, I mean, you right now are talking to about, a fifth of the psychiatrists in the country. So that kind of really puts it in perspective that if you're looking for specialist care, those people that have really complex and enduring challenges are going to find it very difficult to find, the support and the care that they need. Now we know that 9 in 10, so 90% of the people that live on our planet live in the low or middle income country. But then if we look at the research, it's actually the inverse in that 90% of the research on mental health is actually focused in high income countries. So this is a big problem, especially with mental health, because it is different from physical health in that there is a real cultural aspect, because we have, for a diagnostic criteria, you have your threshold of symptoms, but you also have impairment. And that understanding of impairment really depends on where you are. So I kind of liken it to somebody with a broken leg. So you have, 2 people with a broken leg. One is a farmer and one is a businessman. And you ask them, well, what is the impact of your broken leg? And the businessman says, oh, it doesn't really matter. I get in a taxi, I go straight to my office, there's a lift, I get in, I sit at my desk, everything's fine. Still making my money, still able to kind of take care of my family and my needs. You talk to the farmer and you say, well, what is the impact that it's had? Oh, well, it's horrible. I can't work, I can't make money. My family is going to be starving. We're going to be worrying about where we're going to be able to pay, get money to pay for the everyday things that we need. So mental health is a bit like that. So it really depends on where you are. And that's why it's so important to have research on mental health within a country, because what works in one country doesn't necessarily work in another. And you have to understand that culture and that context in order to have the most effective outcomes. And recently, with the Sustainable Development Goals, there has been this kind of real shift to acknowledging the importance of mental health. And I know that there was a lot of argument about what the targets and the goals would be and how we'd include mental health. So it's included here in Goal 3, and particularly in Target 3.4, of looking at reducing premature mortality by really focusing on prevention, promotion, and treatment around mental health and well-being. And so this is something that, now countries are realizing that this is something that they should be working for because it is included as a sustainable development goal. And there's some funding that has come in to help with this. And so there's this whole team, of researchers across the globe that are really trying to figure out what are the best ways in which to do this. So what are the interventions that we have that actually are effective, and how do we roll those out within different countries and make them a success? So if we go back then to thinking about traditional methods of intervention development. This is kind of my pictorial representation of what that looks like. So you have your kind of messy problem, which is like a ball of yarn, all tangled, or fishing wire, just tangled up, a complete mess. You don't know where to start. You don't know what to do. But you begin, you wade in and you start by picking up one strand and start trying to unpick it. And the way that we unpick it with, as researchers, is really looking at existing evidence. We look, are there any guidelines or recommendations that exist already? And what are the underlying theories and frameworks that have kind of come before? And then we also ask experts about their ideas. And those experts are usually clinicians or they're researchers who have done work in the area. And through that knowledge, we begin to kind of unpick and further unpick. And if we're lucky and the stars align, which they don't always do, we get to a really nice solution where we've been able to untangle the whole ball of yarn or fishing line and then put it back together in a nice, easy way that makes sense and is ordered. Doesn't always happen, but that is the idea. So despite this, and despite this huge kind of influx and effort to develop interventions to improve mental health outcomes, we don't see all of these evidence-based interventions available in real life. So a few years ago, after taking a career break to have children, I came back to working and thought, well, why is it that we have focused so much on creating these, what look like to be, really effective and important interventions that can be delivered or were designed to be delivered within these settings, but we actually don't see them. And they're just kind of relegated to journal articles or somewhere in the ether of the internet. And for me, I think one of the reasons, not the only reason, but one of the main reasons is that many times these interventions are developed without any input, or I should say meaningful input, from the people who you'd expect to either supply them or to take them up. And so if those interventions actually don't speak to those people so that they say, I am a provider and I can see the importance of this intervention and I can see its relationship to my responsibility to the people that I serve, and so I'm going to deliver it, or that those people who are the kind of audience, the target group for this, they say, yeah, this makes sense and this addresses things that are really important to me, then it's not a surprise that these things are kind of dead in the water. So community partnership is really vital, not just to intervention development, but anytime you're thinking about policies, plans, anything that you're expecting people to do or to implement, they should be involved and engaged. And that's pretty much why, because if we go back to that idea of this ball of yarn or fishing line, really the problem and then the solution depends on your perspective. So if I'm looking at this ball of yarn, I might see one thing that stands out to me immediately. Oh, that's an issue. I can't, of course this doesn't work because that thing isn't happening. Whereas somebody else who comes from a completely different experience or training might say, no, yeah, okay, but have you seen this? This is the first thing that I see. It's kind of like one of those art paintings where you look at it and what is the first picture that you see? It really depends. And so then also what you see as what should be the solution and what we should be doing relates to that. So if you're only focusing on one color, so the blue at the top, you're missing out on the other three. And that means that those stakeholders who see those issues as the real problem are going to say, yeah, okay, somebody's trying to do something, but actually they're not dealing with the problem. They're just doing something else externally. And so you're losing that buy-in, you're losing that momentum to actually have impact. So the only way to do that is to kind of change what we're doing. And I'm not suggesting massive change, it's not radical. I'm just saying, let's expand this expert opinion to actually include all of those people. You want to include anyone who would take part in an intervention, who would be a gatekeeper to allow or prevent somebody from taking part in an intervention, and also those people who would have to fund said intervention or deliver it to be part of this conversation, to be part of coming up with a solution. Because, who is it to say that we're the only ones that can come up with an idea? And what we want, if we're going to really think about implementation and sustainability, is something that's simple. So it doesn't need, anything kind of all, bells and whistles, doing all sorts of things. That just makes it even harder for the uptake to happen. So what we want to do is to get as many ideas as possible of different ways that we can tackle a challenge in order to improve an outcome. I don't really care how we do it, as long as it's not hurting anyone, if we are meeting that challenge and actually coming up with the outcome that we want. So my work then focuses on a particular group, and I think particularly for adolescents, it's a great group to use this participatory method, because although many of you are probably not that far off of adolescence, away from adolescence, if you go back to kind of a teenager and ask them, or you say, oh yeah, this is really cool, you say, yeah, whatever, like it's something else entirely. So it's really important that we include young people in this process, because what I think the kids will find hip and cool definitely isn't what they're going to find cool. And so my focus is really on adolescent perinatal mental health. So we're looking at the pregnancy and the year after birth, and what are the things that we can do to support young girls. So globally, there has been this real focus on prevention of pregnancy, which is great. And it's an important thing to do. But we also have to recognize that there are girls who become pregnant, maybe because they want to, maybe because it's planned. It's not for us to say that this is, no, you shouldn't do this. And, we tried to help you and you've done it anyway, and we're going to wash our hands and, move on to the next person. But we really have to think, how can we ensure that, this girl and this child still have the best shot at life, and they still have the opportunity to achieve their goals? It might be changed goals, or it might be the same goals, but to still do the things that they find meaningful and have the life that they want. So for adolescents, we talked about the onset of mental health symptoms. For women, childbearing kind of age, having a baby, becoming pregnant is also another vulnerable stage of life. So it's no surprise that when we put those two things together, that young girls are at heightened vulnerability for mental health problems. And an estimated 1 in every 2 girls will experience a mental health condition during that time. I focus on Mozambique and Kenya primarily because those are 2 countries that have particularly large populations of young girls that are experiencing this. So Mozambique has the highest rate of adolescent pregnancy. That's the proportion of young girls who become pregnant within that country. And Kenya has the 10th highest absolute number. So just by sheer size of the youth population, they have significant numbers of girls who become pregnant. Now, you can say, because there's this push to reduce pregnancies, like, why are we focusing on this? It's not really a problem. And it's true that globally, the proportions of girls that are becoming pregnant are reducing. But as I mentioned in Kenya, for Africa, because the population is so young, that even small numbers, if that population of youth is still increasing, will have ever more kind of absolute numbers and higher absolute numbers of pregnancies. So it's by no means a problem that is disappearing. This is something that we still really need to be focusing on and taking seriously. And sadly, there haven't been any interventions that have been evaluated specifically for this group in sub-Saharan Africa. So there's much need for this type of work here. So the Inspire project is really focused at this. This is the focus of my fellowship. And what we're aiming to do is to actually develop a scalable and sustainable way to support adolescent girls' mental health during the perinatal period. And we're working across partners. So within the sites in Mozambique, we're working with the International Center for Reproductive Health. And we're also working with the Aga Khan University in Kenya. So there are amazing site teams who are kind of leading all of this work and who are really driving it. So although I'm the primary investigator, this project does not work unless they take ownership and they're doing these things. So I'm much more of a facilitator than I am kind of the driving force. So they're making choices. There are issues where they want to defer to me and say, well, what should we do? And I always put it back to them and say, well, what do you think what will work in your setting? What is your kind of gut reaction? What are we going to do? Because it's not my place to say, what to do in either setting. I haven't lived in either setting. I've visited and you kind of know it in that way, but I'm not the person to make these sorts of choices. And for them to lead it and then to make sure that the communities are also then engaged and buying in and leading that so that it's something that's coming from the ground up rather than from the top down. And then in the UK, we've joined forces with the Royal College of Art at the Helen Hamlin Centre for Design, and they're providing a lot of human-centered design expertise within our Centre for Global Mental Health, of which I'm part of, which is a collaboration between King's College London and the London School of Hygiene and Tropical Medicine. We also have an implementation science group who is pulling together, a lot of the support for this. And in addition to human-centered design and implementation science, we're also blending in a systems thinking approach. And that's partially because we want to make sure that not only, is the intervention aligned with what people want, but we're actually thinking about the existing system in which it's going to fit in and to determine what are the best places in which to deliver those. What are our delivery strategies? And that kind of comes in with that approach. So how are we going to do this? So we started data collection in November. So it hasn't been that long, but we've done quite a bit. So first, we're actually trying to develop this intervention. So we're using traditional methods. So, one-to-one interviews with adolescent girls. We're using focus groups with partners, with family members, so heads of households, because they're really important to get on board because they will either encourage or provide a barrier to a girl participating in any intervention that's delivered for her. As well as community influencers, as we call them. So that might be head teachers, it might be a pharmacist, it might be someone from the adolescent sexual health group, people that the young people will look up to, and potentially, their word to say this is a good thing might help not only them, but their families and the partners to say, okay, this is something we should do. Religious leaders, traditional healers, all of those included in that. And then we have community-based service and health service providers, because we want to know, when they're engaging with young people, are there also places that we can kind of fit in some of these intervention components? And kind of national and local governments, because we want them to see that this aligns with any plans that they have currently or plans that they're putting together for the future. And the idea then is that we pull all those things together, and we're doing some less conventional methods as well. So we're using photo voice with the girls, which is a method in which we give them cameras and some instructions of what to take pictures of around their neighborhood and in their homes, so that we can learn things about them. What's the first thing that they see when they wake up? Who is the person that they go to for support and advice? And then also doing something called a spiral walk, where our researchers go on a walk around a fixed location. So it's either a girl's home or the health center, and they walk in concentric circles to see what's out there. So we want to know, where are places that girls go and feel comfortable going to, and what are they doing there? Where are places that they'd like to go to, but they feel for some reason they're not welcome, or it's not, a good thing for them to do? Where are places that they definitely wouldn't go to, and who are people in the community that they might be avoiding? And we do that also then to figure out what that delivery strategy will be, and also identify other potential stakeholders, who are other people we need to bring on board as we develop these solutions. So once we do that, we can come up then and understand what are the priority challenges. If we can agree a challenge amongst everyone, then we can start to think of potential solutions. And once we do that, we try to, as quickly as possible, make kind of visual representation of this. So is it a storyboard? Is it kind of a little skit that acts out a service? Is it a flow chart? Just so that people can see, this is what we're thinking about what the intervention looks like. Because it's a lot easier to ask people, what is it that you like and don't like about this, than to just blanket say, well, what do you think we should do? So we use that process to then refine a prototype. And I think this is one of the reasons that I think I was drawn to human-centered design, because instead of just coming up with a prototype and then just testing it, you can take the time to actually talk to stakeholders and further refine it, so that when you go to testing, at least you think this, we've given this the best shot of working. And so in that test, this is kind of some pictures of some of the activities that we've done. This is in the first Mozambique project that we had. So we had some card sorting activity for some of the girls where we said, here are some of the challenges that you've discussed. We know all these are important, but can you put them in order of importance to you so that we could try to figure out, what was the most important thing that we should address. There's a picture of us looking at a map. So that was part of our mapping of the community to figure out where certain things were and where we might think about delivering interventions. And then our kind of, I think this is like the staple of human-centered design, or Post-it notes. Just tons of Post-it notes, thinking of the main themes that are coming out from the different stakeholder groups with some quotes and ideas as we as a research team and as the stakeholder groups are coming together to try to make sense of this. So we're pulling all these things together for everyone so that we can say, look, these are the things that the different groups are saying. These are where they're aligning and these are the differences. What are we going to focus on? And then we move to the refinement. So this is through an adaptive pilot where we'll deliver the intervention to a small group of girls and then pepper them with questions about, what the content was like, what they liked, what they didn't like, the delivery process, and also ask those providers, what was the training like? Did they feel comfortable and competent to deliver this? What are the things that they would like changed? And through that conversation, we kind of further refine, retrain the facilitators, the providers if that's needed, and then deliver it to another set of girls. And the idea is that over a kind of 18-month to 2-year period, we can do this up to 3 times. This is again, just another process of really trying to refine what we're doing so that when we move on to a trial, we actually have something that, anything that was going to be obvious as a barrier to its success has been worked out. And we can really test something that we think has the best chance of coming up with good results. And then we'll do that at a later point in time. So the funding period kind of stops at the end of stage 2. And our goal is then to have enough data to compel, funder to give us more money to actually test this in the 3rd stage. And so what we want to do then is to look at mental health outcomes. But we also want to ask for outcomes. So, the stakeholder engagement is not just around the development, but it's also around the research process and the evaluation. So what are the outcomes that are important to them? What are the things that they need to go back to their peers and colleagues to say, hey, we were looking for something that did this, and this project is, this intervention is showing that it's actually happening. So now I can, sit there and champion something, and I have the data that my group of stakeholders actually needs to get behind it. So what I want, traditionally, we're just collecting data that's important to researchers or clinicians. And that doesn't necessarily, it could in some ways, but not always, are those the things that are most important to other stakeholders. So we want to make sure that we're collecting that data so that we can give those stakeholders the kind of tailored, detailed information that they need in order to make an informed choice about championing the intervention in future. And so we'll look at those, and we also want to know what are the wider impacts of this intervention on adolescent mothers, because it's, very likely, because we're asking them just about challenges that they're facing during this time, that what comes out of it doesn't on the surface look like a mental health intervention. We're really trying to focus on tangible things because one of the ideas is that if you do that, that's something that people can actually hold on to, and they can see how it relates to a tangible challenge that they have. And so we're kind of pulling in the literature and the evidence about what are the things that we need to do to improve mental health, but we're packaging it in a way that actually makes sense to those stakeholders. And this is kind of what it all looks like if we kind of pull it together in this blending of these different approaches. So our question is, how might we better support adolescent girls during pregnancy and the year after birth? So in this empathize phase, this is where, the first phase where we're just kind of collecting data, we're listening, we're trying to be open to figure out what's going on. So we want to learn about kind of geographical issues. We want to know about the epidemiological data around mental health and the prevalence. We want to know around the socioeconomic issues in that context and culture, look at ethical, legal, and political issues that might be kind of forcing what is happening on the ground. So once we do that, that kind of opens us up. So we start off with this small question, and then we get peppered with all of these answers, and it just kind of gives us this huge array to work with. And so then we start kind of bringing that back down together again. And we start defining the problem by looking at the system structures. We look at all of that interconnection between stakeholders and systems. We want to know what are the barriers to mental health or the challenges that girls have to thrive, and what are the opportunities? Who are those important people who we need to have on board to make any impactful change? And really trying to think about what is it that the different stakeholders want, and how can we bring them together? Because it is, part of the art, it's science and art of how you can bring people together and help people who might not always see eye to eye work together towards this common goal. And so once we do that and we identify something that everybody can buy into, then we begin this brainstorming of solutions and this refinement. And then we kind of begin, once we kind of know what that intervention is going to be like, we begin to further refine it and come up with the detail of that. So what is the intervention? What's our implementation theory? How are we delivering it? What's the strategy, and what process are we using, and what are the outcomes that we're measuring? And so by the end of that, we have a prototype that's actually ready for testing and refinement. So I've gone to about 40 minutes. I'll just stop there. If anybody has questions about this, you think this is something interesting, you want to know more, you can email me always. You can follow me on Twitter or follow our project, which is Design and Mental Health, on Twitter. We also have a website where you can learn a bit more about the project that we're doing now, as well as our proof of concept project, which was the original one we conducted in Mozambique. Yeah, so that's pretty much it for me. And I'll stop now to answer some questions that you might have. Hopefully there are some questions. Either I've stunned you into silence, the food has. Yes.
Thank you so much for coming to speak to us. The question that I have is, and it's kind of based on my own, based on some Bangladesh and Bangladesh, and there's a lot of mental health stigma that I've experienced, and that is culturally, and so that kind of is the basis behind my question, which is, what does, I guess, community participation look like in a culture or, cultural context where mental health is
Yeah. So yeah, you're completely right. So the stigma of mental health is all encompassing in pretty much every place. I don't think I've learned about any place where there's no stigma associated with mental health. One of the things that we do is, we don't go in and say mental health, like we're asking about mental health. We've kind of framed it in well-being, and we talk about mental well-being. So it's kind of the terminology that you use is one thing. The other thing is, I think one of the kind of beautiful things about this approach is because it is stakeholder driven, you're coming up with ideas that people would actually engage with. So in that way, you're developing ideas which hopefully have very little stigma associated with them. I think I'm lucky because I work in, public mental health. And so you can do things on a wide scale. You're not necessarily always targeting. So if it's available to everyone, that also kind of reduces the stigma that's associated with it. So those are the sorts of things, I think, if you're working with communities. There is also an element of kind of mental health literacy and training, just so that people understand what these things are. Like I said, COVID, I think, has had a really positive impact in that way of helping people to understand mental health and, how it can affect anyone, really. So those things, I hope, come together to result in the development of an intervention that has, is less stigmatizing and more people would actually want to engage in. There was another question. Yes.
So I guess it's a bit more medical of a question, but is there like data on like sort of postpartum depression is more common in this community? Because I understand like the population is adolescent in terms of like the vulnerability, but I'm just curious if there's any existing research on whether there's the rates of I think the associated mental health problems.
So I also just realized that everybody has masks on and it might be hard. I'm not sure if the microphones are picking up. So I'm just going to kind of repeat generally what the question was. So the question was about whether or not we know kind of if prevalence rates of mental health, maternal or perinatal mental health are heightened in these low and middle income countries as compared to high income countries. Well, I think it depends, like much of the research, it kind of depends at what you're looking at. So I think there are research studies that show very low rates. There are research studies that show high rates. It's a difficult thing to compare oftentimes because the screening tools that people, or the diagnostic tools that people are using are different. It depends on whether or not that tool has been validated in that country and makes sense and you're getting the right responses to those questions that you're asking. But the idea is that, if we're looking at social determinants and the things that we know that drive poor mental health, then that is very much heightened in many places in low and middle income countries. Not to say that that's the only place, because we do have, places within high income countries where there's lots of deprivation and there are lots of problems that match. But we know that where those things happen, you do see increased rates of mental health issues. So I don't know, does anybody else have anything to add to that? I'm not the only expert here in the room. Okay, so you take my word for it. So there is this thinking that there is this relationship, increased mental health issue in low and middle income countries because of all of the issues that are kind of correlated with poor mental health. But depending on what you look at, you'll see different rates that come out. But I think that the meta-analyses will show that when you pull all those things together, that there is some increase. Yes.
I'm just curious to learn more about especially thinking about how to identify what groups of girls to work with, and I guess I'm always curious about how you get the fundamental piece that's the prerequisite for the participatory research, which is participants who are excited, engaged, have the time, the place to meet, already have some social relationships amongst each other, are you doing this in rural areas of the cities, like how to sort of cultivate and access a group of engaged, empowered, and activated young people, and also how that can show up when you're fine and you're like, I'm in participatory action research. So I guess I can pinpoint is like one question that I have, and then I'm also just curious if the participants have come up with anything really cool or interesting that they're surprised or that.
Yeah. Okay. So 2 questions there. I'll try to do the first one and then I'll see if my brain is working well enough to remember the second one. So the first one was about how do you actually choose and identify stakeholders, especially the young girls, to participate and ensure that that's a kind of wider group. Is that what the question was, or how we narrow that down to a particular?
No, it's working that they're like into it.
Yeah.
Like, are they into your study? Are they actually really? How do you choose people who are likely to engage in that way and then like cultivate that amongst
Yeah. So kind of recruitment for our study is done within health facilities, but also through kind of word of mouth. So we're trying to find that in Mozambique, one of the things that I was worried about, probably in both settings, is whether or not you'd end up with a very specific type of adolescent who is attending medical services for her antenatal care and engaging with services, and what the difference might be for girls who aren't engaging, who might be, that might be an indicator of their greater vulnerability to mental health issues and kind of the surrounding characteristics that we know are risk factors. But in Mozambique, the vast majority of young people are actually, of girls and women are actually going to antenatal appointments. And so we were told, oh, you don't really need to worry about that because it's the high 90s in terms of the proportion that are engaging with mental health or maternity services during that time. And in Kenya, it might be, I can't remember exactly whether or not it was very different within our setting, but we're also working in urban, but also peri-urban settings. So not really rural settings, but in those two types of settings to try to see what the differences are. And there were slight differences in terms of, what people want and what their experiences are. In terms of the engagement of young people, I think there's this idea that young people aren't engaged and they don't care and they just want to do what they do. But I think if you talk to people and you say, you have power in this, we're actually giving you autonomy, like they do want to have control. They do want to have a say. And it was, a really wonderful thing going at a time when there was a big workshop with a group of girls in Mozambique and seeing how well they got on with each other, how they laughed and, participated in the activities and like spoke and, really engaged with each other and with the researchers around the topic and bonded through that point. And I think part of it is that this is a process of engagement that lasts quite a long time. So they, the girls that have been recruited and working with us on this project have been doing so since November. So it's not like we just drop in and say, hey, we want to know this from you, and then we kind of go off and do something else. We are coming back to these girls. They can see, and we tell them, this is, the vision that we have. This is what we'd like to do. And they're part of this journey. And also the fact that we listen to them and we take what they have to say and incorporate it into the things that we're doing so that they know that we're taking them seriously. This is not just lip service of a tick box that we think that we have to check for a funder or something else to say, oh yeah, we talk to young people, but actually they're a driving force and it has to be something that they can stand behind or else it just won't work. So I think it is difficult. So doing this type of work, doing participatory research isn't by no means easy. And I think this is why people don't do it often enough, because it does take time and you do need to build those relationships and you do need to understand each other and have that trust. But if you do it, then I think the benefits of that are really significant. So that was question one. Question two, my brain is not working, so please remind me. That's right. So yeah, so have any kind of wild or new ideas come out of this so far? So at the moment, I think there are two things. One is that people tend to think that kind of innovation has to mean something like you've never seen before, and this is like wild and crazy. And my kind of view of it is it kind of boils down to simplicity. So oftentimes we're not kind of making something that's completely new, but we might be taking things from other areas that might be useful that we haven't used, within mental health before. And so really, and that's where trying to get people with so many different types of experiences and expertise is important, because they might be doing something and see some connection to something that they've done or is happening in their field. And they say, oh, well, have you tried this? Worked for this problem? And that sounds really similar. Like the problems are the same. Could this work? So that's one thing. The other thing is that it is difficult, and we have been finding it difficult, especially with groups where they're not used to being asked and used to being engaged in this sort of manner. So say, our teams are saying, oh, but they're not coming up with things that are kind of wild and wacky. They're saying, could we, some of the problems that have come out of this, that they're saying these are the challenges, is that, young girls, they don't know what's happening to them during pregnancy. They don't know what to expect, and when they're giving birth. They don't know how to take care of a baby. They don't know all the things that they're supposed to do, then they want to do to be a good mother and make sure that their babies thrive. So it's those sorts of things. They're also saying, look, we don't have the money. Like, this is a big problem. We need food for the baby. We need food for ourselves. We don't have the money or the resources in order to meet these needs. Or it's, I want to go back to school, but there's nobody to look after the baby. Or I don't have the money for the fees to go back to school. So what do I do now? Or I want to start a business, but how do I do that? So these are a lot of the things that come out. And there are some existing issues, there are existing services or interventions that are there in the community already. So we were talking about making money and starting a business. Well, there are these like loan clubs or savings clubs where people get together and they all donate, they all put in savings once a month, and once a month, one person gets to reap the savings. And that allows them to just put in little bits of money at a time, but still have access to a larger pot to help them with whatever it is that they need to start their business or kind of buy inventory or what have you. And this exists in these communities, but it's not something that's accessible to these girls. So maybe it's, how do you make that existing service accessible? How do you work with the strengths that are already within that community, rather than trying to come up with something new that you bolt on? So anything that's simple, working with what we've already got, making small tweaks, for me, those are the things, that's the innovation, not necessarily kind of completely different things. I know that there are some projects that come up with some really interesting ideas that you would never have thought of. But for us, I'm not sure it's going to take that route where we come up with something that is totally different. Yeah. No. Yeah. Well, it's not a hate of innovation. I think it's just the term and the way that people think about it. Yeah. Yeah.
But I more meant that in terms of what something you wouldn't have thought of because you're not a teenage girl in that position, and more like something from their perspective that was not what they came up with, like that word.
Yeah, I think what has come out from the girls is they just want reliable information. They want to be able to make their own choices, but they want to be able to do so after being, given information and knowledge. So that seems to be kind of coming out quite a bit. And I think that's indicative of just the experience of many of these girls, that all of a sudden, or it might not be all of a sudden, it might have always been this way, that choices and decisions are made for them, not with them, not by them. And so that's what they want. They want what any young person would want, is to be able to have some semblance of control over their lives and to be able to start building that autonomy as they are starting their transition to adulthood. Yes. Yeah.
Adolescents are not the most empowered group out there, as you noted. Do you anticipate any resistance from respected elders, policymakers, healthcare workers towards whatever intervention, particularly you might develop, particularly if it's seen as kind of having come up from this group that's marginalized and seen as powerless and not very important?
Yeah. So I think that we're doing this not just, so although the girls have have more weight in terms of their desires and their needs for this intervention, but we're doing it in conjunction with all these other stakeholder groups. So it is going through that process of being seen. So if there's things that they go, oh, this group, I don't know, this doesn't, well, what is it that you don't like about it? Trying to understand from their perspective, or what are the problems, the potential pain points here that we need to address and think about. But as we go through that process, we pull the stakeholders together, but we always keep those young girls as a group with a facilitator so that their voices aren't diminished and that they can actually say and feel comfortable sharing what it is that they want. We might have time for one more if anybody has a final question. Yes,
I
please.
have so many questions. We will talk. I mean, I'm obviously biased to the work that you do. I think it just makes sense that health service delivery should be rooted within the needs and desires of a community. I guess I don't see how it could be any other way, but it is. And so I was just wondering what you see the main forces are that are maintaining the status quo of health service delivery, and like what needs to happen to shift that status quo.
Yeah. So I think it's partially it's expertise and what that comes up with. And it comes up not just, if you're thinking about the service providers, either in health facilities or community-based services, but it is everyone wants to have their own niche, and they feel like what they provide and what they do is important and kind of essential and necessary. And I think that it is that process of understanding that it can't be one-sided, that you have the supply and you have the demand, and it hasn't really worked for us so far in saying, we have these interventions, you have this problem, so you just do this, you come to the health facility, you talk to this person, when all of the qualitative literature is saying that people don't see the relationship between their mental health issues and going to a medical facility for help and support. So where is it? So we have all of this about this treatment gap. People aren't getting care, they're not, but really that's a bit rubbish, because people are going, they are talking about their problems, they are help seeking, they're just not going to the places or the people that experts think they should. And this is all very behavioral. So we know from lots of other examples that actually behavior change is difficult. So instead of making people change their behaviors and try to access care in the way that we think they should, why don't we try to figure out a way to make the care available in the places where they were normally going anyway? So part of that, it is an ideological shift, I think, and it is around trying to understand and empathize in another perspective. And it's not easy. And there are people who would be much more open to doing this. And I think you need to do that with that stakeholder group, and then to understand the other feelings and how do you get those who are more against this new way of kind of working to try to figure out, well, how do you meet them, or are there ways that we can talk about it so that it makes sense to them as to why it is that we think that this is important. Is it that you're going to argue about outcomes? So what's the most important thing? Is it that we're trying to improve outcomes? Is it that you're trying to keep the money for your facility in your facility? Because that is, we have to think about that some people see it as a threat if we're trying to provide care within the community. If you're a hospital manager and you are getting money from the government and you're thinking, oh, they're going to start taking money from me, then that's something that you have to really discuss and try to figure out. How do you ensure that people are happy? But without really engaging with that and understanding those viewpoints, you can't. There's just no way. So that's why that whole engagement with people and trying to figure out what are their motivations, what are their behaviors, and how do we work with that in order to come to, to address this challenge and come up with the outcome that we all want. Because I think, we can all agree on what it is that we want. It is that process of how you get there. Okay, so I think that's it. Thanks so much, everyone. This is really fun, yeah.